Before I hand over the proceedings to Dr. Mona Bhatia, we've got a request from the organizers. There are the feedback forms available here. Those delegates who haven't filled them, kindly fill them and hand it over to the organizers for a better feedback of this 11th WCCPCI.
Dear friends, good morning to everyone. Today is the last day of WCCPCI, and we are really privileged that we have eminent faculty coming all the way from different parts of the world to address on a very, very important issue is in the imaging track. Innovations, hope or high. We have Mona Bhatia. She is the Chief of Imaging in the most prestigious Escort Heart Institute in Delhi. We have Professor Priya Jagia. She is also the Chief of Imaging in All India Institute of Medical Sciences. And we have Tarun K. Mittal from UK and Apurva Mittal from our own hospital, Mulchan Hospital. He's a cardiologist, interventional cardiologist. And this session, I think each speaker will speak about 20 minutes or so, or Apurva will speak for about 14 minutes. But this has to convey a very important message. And I know Mona and Jagia will do a good job. So ladies and gentlemen, without wasting any time, I present to you Mona Bhatia.
Dr. Chopra, it's indeed a pleasure to be here. And good morning, ladies and gentlemen. So the title of my talk is Why MRI in the World of Echo. Just before I start my topic in toto, I'd like to give you a brief on what MR does for the heart. So image acquisition in CMR is done in the vertical long axis, the horizontal long axis, which is the 4-chamber view, and the short axis view. The 4-chamber provides us a global view of the heart, so you can evaluate all the 4 chambers, the tricuspid and the mitral valves. The short axis evaluates function, wall thickness, and wall motion abnormalities. We can also do views as is required. So you have the 3-chamber view to evaluate the LVOT and to look at the tricuspid valve and the mitral and the aortic valve. The RV inlet and outlet view, which looks at how the RV is doing. And then we can have flow quantification through the aorta and through the pulmonary artery, where we want to have the QPQS, particularly in the congenital heart diseases. So coming to why MRI in the world of echo, the number of patients, particularly in our country, waiting for non-invasive cardiac imaging is truly huge. And echo is the winner because it's easily available, it's portable, it's non-invasive, cost-effective, it allows comprehensive systolic and diastolic function assessment, and it has no risks. So the echo train has stood the test of time. Where does MRI come here, and what does MRI have to offer? Let's look at the first scenario. A dilated LV on echo. Is it ischemic or non-ischemic is always the prime question. So when a patient comes with chest pain and dyspnea on exertion, on echo here you can see that the LV dysfunction is present with regional wall thinning, wall motion abnormality in the LAD territory. The short axis in the Black's view is where you can see that between the MR and the echo you have very similar projections. The scar is seen in the Black's view on echo. So what else do we need the MR for? We've seen it all, we know it's ischemic. Well, the critical question in ischemic heart disease is function, perfusion, and viability, which form the basis of risk assessment and for stratification, where this patient goes, management, and prognostication. CMR today is the gold standard for ventricular function and volumetrics. We have a very high spatial and temporal resolution with very accurate delineation of the endocardial and epicardial borders. So we have accurate, reliable, and reproducible calculations of the end diastolic volume, the end systolic volume, ejection fraction, cardiac output, and for myocardial mass. In the evaluation of LV and RV function, CMR is most accurate because with echo, the coefficient of variation or the margin of error is 11.5%, whereas with CMR, your margin of error is 3.7% only. What are the additional findings we see on MRI? We can evaluate the myocardium for fresh edema on T2 weighted imaging, and that then helps us to differentiate acute from chronic infarcts. We can look at perfusion defects, and here you can see the contrast coming in, I'll just wait and show you, it comes into the RV, comes into the LV, then it perfuses the entire myocardium and you can actually see the myocardial defect, the perfusion defect within the septum. And this is the corresponding scar, which is subendocardial on late GAD enhanced images. So not only does CMR help us to look for scarring, but it also helps us in quantification of scarring for extent, transmurality, and percentage of myocardium involved, which then helps us to guide therapy. Is it transmural or not? There are various complications of ischemic heart disease that we're always interested in, like an apical thrombus. On echo, this can often be confused with reverberation artifacts at the LV apex, particularly if it's a soft, fresh thrombus. On MR, on the contrary, you can see that there is a very well-defined perfusion defect and the corresponding thrombus. So it's easy with MR to actually evaluate certain areas which are difficult to evaluate on echo. Small thrombi are easily missed on echo, but they're very well seen on the CMR. So in the detection of LV thrombus, CMR is superior to non-contrast and contrast echo. Another important differential that becomes difficult sometimes on echo is the aneurysm versus the pseudoaneurysm post-IHD. So here you can see there's a large LV aneurysm with an apical thrombus. The infarcted thinned myocardium is seen as a white and enhancing line with wall motion abnormality and adjacent thrombus and the perfusion defect. You can see the contrast coming into the RV, LV, and you've got a perfusion defect here. Here you can see the myocardium is a scarred line and the thrombus within. This was a 48-year-old patient, hypertensive, type 2 diabetic with coronary artery disease, post-PTCA with a stent to the RCA and the LAD in September 2013. The patient was from Orissa. He goes back with fever, cough, bilateral lymphedema. A diagnosis of diabetes with urosepsis and ARF was made in view of his history and condition. On echo, interestingly, they found a cystic mass in the posterior basal IVS. The patient was then referred to our organization where there was a cystic solid mass seen in the basal IVS. Now the question was, is this a pseudoaneurysm? Is it a drained abscess? Are there vegetations? So, knowing that MR may help solve the solution, we went on to do an MR. At cardiac MR, there was an extensive RCA infarct along the LV inferior wall, the RV, and the septal involvement. A perfusion CMR was done, and here you can appreciate the LV pseudoaneurysm. It has a very narrow neck and intracavitary thrombi. You can see on the perfusion images as the contrast flows through the RV and then into the LV. Here you'll watch it. It comes into the RV, and then we see the contrast coming into the LV and then filling in of the pseudoaneurysm. So CMR is particularly useful here, and the patient then went in for a CAG. There was an RCA in-stent restenosis of 100%. So CMR shows great promise in differentiating these two. The next situation is an LV dysfunction with global hypokinesia this time. So if we have global hypokinesia, where would cardiac MR add value? On MR again, we're seeing the similar images of the global hypokinesia. On T2 weighted imaging, you have global patchy myocardial edema, which is seen in this patient, but this time you have no perfusion defect. So this is not ischemic. You can see that the contrast fills from the RV into the LV, and the entire myocardium is perfused very well with no defect seen. On late GAD enhanced images, the patient had subepicardial and mid-wall scars. Here you can see that the subendocardium is quite clean. All the scars are either in the mid-wall or on the subepicardial side. In our country, the differential is always TB, and this was versus sarcoid. Accessory findings included mediastinal lymph nodes, and on biopsy, this turned out to be sarcoid. Late GAD enhanced imaging is actually now the cornerstone for differentiating ischemic from non-ischemic cardiomyopathy on CMR. While the scar in ischemia is subendocardial in location and follows the coronary artery territory, those that are non-ischemic are usually mid-wall or epicardial like we've just seen. They often spare the subendocardium and do not follow the coronary artery territories. The extent and transmurality of scars definitely have a prognostic value and guide management. Fibrosis in DCM prognosticates death hospitalization, sudden cardiac death, and VT. And in patients of sarcoid, the presence of late GAD enhancement is linked to prognosis and outcomes. My next patient is a patient who presented with VT. The echo was quite unremarkable. On MR, what we found was myocardial tissue characterization showing an acute myocardial edema on the RV aspect of the septum. The corresponding scar was seen on late GAD enhanced images, and this definitely was on the RV aspect, and this then helps guide therapy and ablation. My next patient is a 13-year-old who came to us with DCM and an ejection fraction of 30%. On T2 weighted imaging, there was extensive myocardial edema all through the LV. This was definitely acute myocarditis. Additionally, there were multiple mediastinal lymph nodes. There was a pleural effusion and a pericardial effusion. The patient on late GAD enhancement demonstrated multifocal enhancing nodular lesions which were granulomas, and so a lymph node biopsy was done, and this was tuberculosis. So CMR now isn't the appropriateness criteria for evaluation of myocarditis, where positive cardiac enzymes are seen without obstructive atherosclerosis on angiography. Let's go to scenario 2, a hypertrophic LV on echo. Here you can see that there is always a suspicion in certain echo-silent areas. The MR, on the contrary, very clearly shows the apical hypertrophic cardiomyopathy, and in the evaluation of potentially echo-silent segments like the anterolateral LV wall, the apex and the posterior segment, MR is useful. MR allows accurate LV mass assessment, and a wall thickness of over 3 centimeters is an independent risk predictor needing ICD. MR also demonstrates areas of focal scarring and interstitial fibrosis in these hypertrophs, and the presence of late GAD enhancement shows a trend towards predicting sudden cardiac events. The risk stratification actually changes based on the late GAD enhancement. When there's no late GAD enhancement, it is lowest risk, whereas if the CMR shows a late GAD enhancement of over 15%, it has the highest risk and ICD implantation is needed. This is a very interesting case who went through probably multiple hospitals, and the patient was suspected as a hypertrophic cardiomyopathy with an LVOT obstruction. There was a very, very thickened apex, and it had sinusoids going within it, together with the presence of this structure that was seen bobbing in the region of the LVOT. Since there was a controversy on the diagnosis, the patient was sent for CMR. On CMR, there was thickened infiltrated myocardium with edema, there were crypts within it, and in addition, we could also see the same focal lesion in the LVOT. The diagnosis was still not certain. There was extensive myocardial scarring within the myocardium, and so the patient went in for histopathology, and there were multiple myocardial biopsies taken, which showed that the myocardium was studded with hydatids, and that was a cyst in the LVOT. Hydatid cysts have been seen by us, and they are usually more intracavitary cysts or cysts within the myocardium, but they're normally very well defined. An echo demonstrating a very clear cyst, which was just superficially within the myocardium. There you can see the same on MR. The MR is done more to characterize the contents of the cyst and to look for any enhancement. MR depicting the cyst rather very well, and on post-contrast and perfusion images you can see that there is a non-enhancement and there is a perfusion defect in that region. This was another patient who presented with concentric LV hypertrophy with biatrial masses. In view of the controversies on what could be the etiology, an MR was done. On MR, we found the decreased cardiac function, thickened myocardium in the LV and the RV with thickened interatrial septum. The biatrial masses were thrombi, so it was a myeloid infiltration which was seen as bright signal on pre-GAD, and post-GAD we had the classic appearance with circumferential enhancement on post-GAD images. So CMR definitely has the advantage of superior myocardial tissue characterization. My next patient, a patient with BPCs, on echo it was a dilated RV and there was a suspicious outpouching that was seen. So the patient was then sent to CMR. There was a regional RV wall motion abnormality with end diastolic volume being increased and a reduced ejection fraction. You can appreciate the RV is dilated there is dysfunction with regional contraction of abnormalities and localized aneurysms. Besides, there was also fatty replacement of the RV wall with not only fatty but fibrofatty infiltration, which was rather well depicted. So CMR today is in the revised task force criteria for ARVD, ARVC. Pericardial assessment, CMR does excellently. Patient here on echo demonstrates a septal bounce. The question is pericardial effusion, thickening, what is the thickness, and whether they need to go for pericardiectomy. On CMR, we can well evaluate the pericardial thickness and talk about the myocardial adherence and dysfunction. So here you can see the septal bounce which is seen, but in addition you can see the very well demarcated pericardial thickening with effusion and enhancement. So this was an effusive constrictive pericarditis. I'd like to talk a few lines on GUCH, which are the grown-up congenital heart patients who are now presenting post TOF repair. The current challenge is these are patients who are follow-ups after the 1980s and 90s for the post TOF pulmonary valvotomies and the annuloplasties that were done. These patients have chronic pulmonary regurgitation, which has a detrimental effect on the RV. There's increased risk of arrhythmia and SCD. The RV function needs to be assessed and quantitatively evaluated, and CMR provides the golden standard for RV analysis. So here you can see the RV dilatation, the aneurysm with the free PR that is well evaluated. The RVOT is really dilated, and you can see some multiple excrescences or outpouchings from it. The RV volumes can be calculated quite well with MR, and you can see the aneurysm of the RVOT. Quantification of the regurgitant fraction is very well done, and the imaging focus in these repaired TOFs is pulmonary regurgitation, RV dilatation and dysfunction, tricuspid regurgitation, residual RVOT obstruction, branch pulmonary artery stenosis or hypoplasia, residual VSDs, LV dysfunction, progressive aortic root dilatation and regurgitations, and proximal coronary artery gauze. So the proposed criteria for pulmonary valve replacement in asymptomatic repaired TOF patients with PR, and those are rather stringent, and they're then evaluated by CMR. This is a patient who was 40 years old with a poor echo window and all chambers being normal. No regional wall motion abnormality was seen. The normal LV function was expected. The patient, however, when CMR was done, there were patchy areas of myocardial edema on T2 weighted imaging. The ejection fraction was 43%, and there was a mid-wall scar within the septum. Additional findings were there was mediastinal lymph nodes, and there seemed to be lung lesions on the MR. In view of the situation on MR, the patient was sent to CT. On CT, there were large calcified, rather confluent lung lesions with lymph nodes. So this kind of an appearance we normally see in progressive massive fibrosis with silicosis or Kohlberger's pneumoconiosis. In view of that, I called back the patient and I asked him what does he do, and he was a driver in a stone quarry. So this was pneumoconiosis with cardiomyopathy. Other occupational health hazards are known. This is a 35-year-old offshore oil rig worker who had long weekends, recreational alcohol, drugs, and he came with this patchy RV and LV myocardial edema with subtle enhancement at the inferior junctional myocardium. So these are also situations where CMR helps. So maybe a lot of people after weekends should go get a CMR done. Going on to CMR in non-compaction, this is a classic appearance of what CMR can do for non-compaction. These are the LV trabeculations and the deep intertrabecular recesses that can be well demonstrated. Here you can see the thickened and spongy hypocontractile LV apex. CMR is also useful in cardiac masses. There's always a challenge when you have an RA mass. Is it an atrial myxoma or is it a thrombus? And CMR is particularly useful in demonstrating these lesions. This was a left atrial myxoma with a very typical location right on T2. And this, on the contrary, was an atrial mass, which was a thrombus post-CVP line. So CMR helps to differentiate myxomas from thrombi. This was a lymphoma. You can see the extensive involvement, which is seen within the mediastinum with intracavitary involvement. This was an aggressive angiosarcoma. The patient had presented with tamponade and hemopericardium. The right atrium was on the right atrium, there was a broad-based heterogeneous lobulated mass, which was large intracavitary component. There was central necrosis, which was encroaching the IVC. There was violation of all the fat planes with extracardiac extension into the pericardial cavity with pleural and pulmonary metastases. So definitely CMR is in the appropriateness criteria for evaluation of cardiac masses. Not only is it helpful in diagnosis, but CMR also helps prior to radiofrequency ablation. When you have challenges of EP, EP is always time consuming. There are risks associated with inducing VT. There's limited coverage which may miss lesions, long fluoroscopy times, and CMR helps in detection and characterization of the scars. The advantage of CMR is you can have the scars, their parameters, their transmurality, and once you have that, you can use that for bipolar voltage and scar transmurality correlation. It helps to predict successful ablation sites and reduce procedure and fluoroscopy times. So CMR is now in the appropriate criteria for management of patients with VTs. CMR also helps in valvular assessment. So here's a situation where the aortic valve is rather well seen. Unfortunately, the movie didn't work. Here you can see the aortic stenosis. So you can see the jet going through the aortic valve. This was a patient with valvular regurgitation. Here was a patient who had an aneurysm of the sinus of Valsalva off the non-coronary cusp. So CMR helps in characterization of native and prosthetic cardiac valves. CMR is also useful in other congenital heart diseases like ASDs and then VSDs. And so CMR is now in the appropriateness criteria for congenital complex heart diseases. New advances look at evaluation of coronaries, which help to delineate the coronary morphology and proximal stenosis. And here you can see there's an anomalous RCA, which is seen on MR. So while echo remains the modality of first choice, with the advantage of a rapid and reliable assessment readily available on the bedside, wide capability, safe with no radiation, the limitations are it's qualitative, it's subjective, there's operator dependence, and the acoustic window can sometimes be very difficult. CMR, on the contrary, plays a complementary role to confirm the diagnosis, establish the etiology, assess the severity, guide management, prognosticate, and follow up these patients. Thank you so much for your patient listening.
Yes. We'll have the discussion at the end of the session. It's a very, very interesting talk by Mona, and I'm sure it will provoke a lot of discussion at the end.